All right. So the Informs Health Application Society is excited to present Dr. Ozlem Ergun's work. So she's a College of Engineering Distinguished Professor and Associate Chair for Graduate Studies in Mechanical and Industrial Engineering at Northeastern University. Her research focuses on the design and management of large-scale and decentralized networks, and this work has seen many applications in critical systems, including transportation, pharmaceuticals, and healthcare. Um, Dr. Ergun is also very involved in the Informs community as well as operations research community broadly. She was the president of Informs section of public programs, service and needs in 2013, and she is an Informs fellow. She's also an area editor in many Informs journals, including Operations Research and MSOM, where she's the department co-editor for Environment, Health, and Society Department. So without further ado, I'll let her go ahead and take it away. Thank you.
All right, thank you, Jan. So I want to check something. Are you guys seeing my full screen in presentation mode, or are you just seeing the slide? Because I was confused about that. Okay, cool.
Yeah, we see your full screen.
All right, cool. And I am not able to see the participants or questions for some reason. Okay, now I can see it. But if there is a, I just wanted to say that if there is a question, you can just probably unmute yourself and jump in. I know that we don't have too much time, but I'm also happy to answer clarification questions as we go along, rather than wait for them to be, keep confusing you until the end of the presentation. So Gian and Lauren, so we're starting at 110. What should I imagine? Like I can try to go fast, or what do you think should be the plan?
Yeah, I guess maybe we can still try to end at 2 just in case people have other meetings that they need to hop onto. And yeah, help manage time in any way, just let me know.
Okay. All right. Okay, so good afternoon. I'd like to talk about pharmaceutical supply chains, and mostly focusing on, or like mostly stemming from the concerns around drug shortages that is an issue that is epidemic in the United States, but not only in the United States, but kind of across the world, including EU countries and so on and so forth. So this is what I'm going to do today is really talk about a few aspects of the work that I have been doing with a large group of people over the last almost 10 years at this point. So we've had many students and postdocs that went through our groups. And then the other faculty members who have been working with me on this is Jackie Griffin, who's another member of the industrial engineering faculty at Northeastern. And then we have quite an interdisciplinary group, including Stacey Marcella, Casper Harteveld, and David Cayley, who are coming from different aspects: computer science, psychology, gaming, and so on. And the focus of today's talk is really on the impact of human behavior or corporate, or stakeholder behavior on the drug supply chains and on shortages, and trying to understand and model that. All right. So drug shortages, essential drugs have been in shortage for a very long time, at least for 2 decades in this country. It has become, so all of these clips are actually, clippings from the newspapers are actually taken before COVID, where I would say the regular public was not really aware of this problem. But if you went and talked to pharmacists, practitioners, you knew that this was a huge problem that existed at the time as well. With COVID and kind of supply chain disruptions that came with COVID, I think the drug shortage issue became more known to the general public, with like the Adderall shortage that has happened, that still is happening over the last kind of a year, as one example that probably most of you have read or heard about on the popular press. But as I said, this is not an issue that is new. So on the right-hand side figure, you can see the number of new shortages between 2001 and 2022, although it seems like we're kind of like dipping down a little bit, it's still that we're getting over 100 drug shortages a year, new shortages a year, and some of these shortages actually never gets resolved. Like Adderall is going on for a year, but it has not been resolved. The other thing that is interesting here is if you look at to the pie chart on the left of the screen is the fact that when we look at the causes of these shortages that are reported on either by FDA or at this University of Utah's there's a group at University of Utah pharmacy that collect a lot of information about drug shortages. If you look at their databases, what we see is that while supply demand and manufacturing issues seems to be a big reason, a big chunk of the reasons for drug shortages, the largest proportion of the kind of the cause is actually unknown. And this is, I think, what kind of piques our interest in my group, in the sense that we have a huge problem. It's a big public health issue. And at the end of the day, we cannot even say why this is happening. And and what we believe is that like the reason for this is that there are many different issues that are going on. It's a complex system. It's a system with very low data availability and visibility. And that causes not only the shortages, but also makes it very hard to analyze what's going on. So again, I'll go back to Adderall. If you look at the Adderall shortage and all the information that became available to the public, there is really no one who could say exactly what was happening. I've gotten interviewed in the popular press for this, and every time a reporter asked me why are we having a shortage, I gave a bunch of different possibilities. We couldn't really point out to what exactly was happening. There are a lot of pointing fingers by different stakeholders to others, right? But there is really no kind of data-driven evidence of what happened. All right, so we also work with, our group works with a couple of hospital systems in the Boston area. So with the Massachusetts General Hospital, we actually engage with their supply chain managers at their pharmacy. And we do interview them every week, actually, for many years now. And we ask them, how bad is it? Like one of the things that we ask them is like, how bad was the week between, like 0 to 10? And you usually get like a 7 or an 8. And this graph at the bottom is actually the data that we collected from MGH that shows the number of drugs that they see in shortage at their hospital. And if you look at this, it's a huge number. And in MGH, several members of their pharmacy supply chain team actually spend a majority of their time dealing with shortages each day. So it's a big issue. And it's not only an issue in the sense that obviously it has negative impacts on the patient's health, but also it takes a lot of time and effort and finances from many different parts of the supply chain teams to manage these shortages. So one example is saline that we like to talk about. It's kind of an older example, but it's a product that has always been it's always been a problematic issue. And it's interesting because saline is just salt water. It just has to be sterilized. And not surprisingly, it is used widely in many different applications, all the way from hydration to dialysis and surgery to chemotherapy. So when you have a saline shortage, it is a big deal. It actually affects many different parts of the healthcare system. So as I said, we use it a lot. And saline, so this is kind of going back almost 10 years now. It was in shortage from January 2014 to 2016, mostly we believe due to kind of manufacturing issues and recalls. However, I'd like to point out that even with this kind of like manufacturing issues, we say, there was really not any one big manufacturing recall or shortage. It was all very small recalls that were, kind of done by the very few manufacturers. But when you add all of those recalls together, it actually created a persistent shortage. So what happened then was Hurricane Maria hit Puerto Rico. And it turns out that almost 80% or more than 80% of saline production for the entire United States was in Maria. And if you're surprised about this, or if you have not heard about this before, you should also know that actually there are a lot of drugs that we use where more than 80% of their production is in Puerto Rico. And that kind of seems crazy in a way, if you think about it, right? Because at the end of the day, Puerto Rico is an island that's under the hurricane belt. So there is a high risk of disruption. So saline was already a troubled product. Maria hit, and then there was a huge shortage. And I like to also say a few words about this from my own experience. I was, after the 3 big hurricanes of that year, I was actually called on a National Academy's committee that wrote a report about strengthening supply chains after these hurricanes and analyzing what happened. And one thing that was really drastic when we look at Puerto Rico for Maria and the drug shortages issues, I actually talked to someone who made the decision of not giving fuel for the power generators for the pharmacies who were producing saline. So what happened basically with Maria is that the production facilities did not get damaged, but the power infrastructure went down, and for a long time. So actually the manufacturers were prepared in the sense that they actually had generators. They could run their manufacturing processes with the generators, but after a while they just ran out of fuel. And they were trying to find fuel when they contacted the emergency management that was running the operations in Puerto Rico at the time. Basically, the guy who made the decision said that, I asked around, I said, like, is this important? And nobody could tell me that this was important. So I said, like, we were not going to allocate any fuel to these manufacturing facilities. 6 months later, we were still canceling heart surgeries in the mainland United States because we didn't have saline. So the issue here, again, like another issue here is the fact that there is very little visibility of the supply chains for drugs. And even under an extreme case like Maria, when the decision maker is trying to make a decision around allocating fuel, this person might not know if this is important or not, right? Because they have no idea the criticality of saline or the supply chain mapping of the saline, understanding of like a major, basically all of saline production is done in Puerto Rico for the entire United States, right? So that's the problem. So in conclusion, we understand the trends in shortages, drug shortages, but there's a poor understanding of which system features are contributing to this behavior. And at the end of the day, everything contributes to these shortages. There isn't really one kind of culprit, and it makes it hard, and that makes it hard to resolve the problem, right? There are problems at kind of importation, there are problems in manufacturing, transportation, inventory practices, and then a lot of ordering practices and hoarding type of activities at the clinical level also exacerbate the issues. So it's a complex system, not so, that shouldn't be a surprise to this audience. And there was, after or during the COVID, we also had another National Academies committee that I took part in, that really just focused on medical product supply chains. So if you're interested, this report is also available online for free from the National Academies website. And it's a long report, but it kind of discusses all the things that I have talked about until now. So again, going back to some of the issues and why is the system complex? Again, I apologize, maybe this is not so kind of not earth-shattering for this group, since we're all supply chain experts and operations experts here. But there is, if you look at data, so this is ordering data between the warehouses, or sorry, top 4 distributors in the United States, and for each state, which distributor they get their products from. So the 4 colors are the distributors, but what you see is that there are many states where they do get their products from different distributors and not necessarily regionally identified or kind of clustered. So there's also, it's a network system, so you get propagation of an issue through the network. So for example, if you have an issue in the distributor, orange distributor, obviously we're going to see problems potentially at the blue hospital. But at the same time, if there's a problem at this navy distributor, we will still see some problems happening at the blue hospital, although the blue hospital is not a direct customer of this distributor, right? I mean, this is, again, for this crowd, this is not surprising, but it's a network system, and you have network, you do have this kind of propagation of problems throughout the network with a lot of delays and lead times, and it makes it a kind of a complex system to analyze. So furthermore, since this is an industry where there are a lot of disruptions, it is also interesting to understand that there are many different disruption profiles. Like we might have a brief and a very large disruption versus kind of not a huge disruption, but like prolonged over time. We could have kind of a single continuous disruption versus many small disruptions coming one after another. And it turns out the impact of these different types of disruption profiles on the supply chain and the final impact at the health center levels are very different, actually. So again, another complexity in terms of, if we're trying to solve this problem, one of the things that we really need to understand is what is the disruption profile for this particular product or for this particular supply chain. Furthermore, another thing that makes these issues quite complex is the substitutability of the drugs and kind of the correlated trends in terms of drugs that are going into shortage. So for example, you might have an antibiotic that goes into shortage, and then that causes a lot of the health systems to move from that product to another one that is similar. So after a while, that product also goes into shortage because its demand also goes higher, and so on and so forth. So again, there's all these kind of substitutions and that creating not only shortages on other drugs as well, but just kind of like really unexpected results too. There was a point, for example, during the saline shortage, the health systems were trying to save saline, so not using like very big kind of bags, just like kind of going into IVs. They were trying to actually use syringes to take the solution and then inject it into the patients so that they could save the saline and kind of ration it. So then what happened was, after a while, actually in the Boston area where I live, we started having a shortage on syringes because the demand on syringes really increased. And there was a kind of an anecdote where the Boston Children's Hospital completely ran out of syringes and had to kind of like really go to the other hospital systems in the area and borrow syringes. So a lot of these kind of unexpected effects also happen in the system. So what I'm really interested, or like what I'm really going to talk about today for the rest of the talk is looking at what happens, like what are maybe some salient features of decision-making and agent behavior in the system, and how is it impacting shortages. So as in most supply chains, this is a decentralized decision-making system, and there are the types of decisions that the decision makers are making are kind of ordering and allocation of their stocks into their customers. So they're and dealing with inventory and backlog cost, and also dealing with market share type of issues, right? of course, within the healthcare context, we could have backlog costs that could be really, really high. And that causes a lot of kind of emotional behavior on the ordering side. So for example, so before going into that, for example, when we talk to pharmacy supply chain managers at hospitals, most of them will tell you that the way that they order is to kind of guess what is the max amount their distributor will give them, allocate to them, and order that amount. Like it has actually nothing to do with their demand or what they need at the time. So you can imagine like a system where everyone is just trying to order to the max allocation they think they can get, right? So that's causes a lot of hoarding, which exacerbates the issue. That also sends a lot of like false signaling on the actual demand amount, and it causes like this whole havoc in the system. So also, as I said before, there's very, very low visibility. This is an issue that a lot of the kind of the national level reports have been like calling on and asking for actually executive action or policy action on creating some kind of a structure where either there is a mandate on reporting on supply chains or for drugs, or at least creating some incentive systems for creating more visibility on the drug supply chains. So again, my perspective on this for this talk is the fact that when you have very low visibility, it actually increases the irrational behavior of the stakeholders, particularly on ordering, right? Because if you're a hospital supply chain manager in the pharmacy department, and if you have no idea if this drug that your distributor is telling you they don't have right now is going to become available when, how, what is the current inventory situation in the region, in the country, you just keep ordering. You just keep ordering to the max. You keep ordering so you don't lose your space in the queue, and that again creates all sorts of weird signaling and problems in the supply chain. So again, all of these issues in general leads to an extremely high variable ordering behavior, and it's mostly based on kind of these trust issues, like kind of looking back a few periods before and saying like, okay, this distributor sent me this much, the other one sent me that much, so let me just like kind of move and shift my ordering from here to there. And as probably you all know, that creates a whole kind of a whiplash effect in the high supply chain, because then the distributors are getting all these variable orders and they don't know what to do with that, and so on. And there is the hoarding behavior. So for the rest of this talk, I'm going to talk about a couple of different avenues of research our group is doing, trying to understand. Some of it is based on like the goal is to understand what behaviors are causing, and some of it is trying to see if we can build decision support systems that will help with better decision making. Okay, so the rest of this talk and our work is not actually very analytical. It's very empirical and experimental, partially because we believe there is a lot of complexity and interaction, and kind of abstracting out analytical models does not really capture everything we want to see. So the research infrastructure that we have and we've had for at this point for many years is as follows. So we have a flow simulator in the middle, and that simulates ordering and kind of order propagation and like physical movement, the propagation of the physical movement of the commodities or the drugs in the supply chain system. And then we have on the right-hand side here, we build decision-making models using different types of ideas. So I'm going to talk about two different ways of decision makers that we modeled. One is based on the system idea that comes from kind of computer science / psychology, which really kind of looks at the system and tries to propagate the impact of a decision in the system and then makes the best decision available. I'll talk about that in detail in a second. And the other one is looking at this RL reinforcement learning type or deep reinforcement learning type of agents that we have been looking at more recently. On the left-hand side, we also built an infrastructure based on games or gamettes, which are kind of really small games where you can put a human decision maker into your simulation and let them play the game as the simulation is running with other types of decision makers. And we collected, over the years, we've collected a lot of data. And what we do is we go back and we do two things. One is we go back and analyze what the human players actually did and kind of try to understand why they did it, or kind of different types of behavior patterns, and how is, for example, giving more information changes these behavior patterns for different types of, groups of people. But we also use this information that we collect empirically to kind of refine and kind of validate our analytical decision-making models that we're building on the right-hand side. So that's kind of the idea of our research framework. So let me first, so what I'll do is I'll talk about three things. One is I'll talk about some results that we have coming from when we employ decision makers using this theory of mind or PsychSim framework. And then I'll talk about what the type of things that we're observing when we build decision makers that are using reinforcement learning type of models in making their decisions. And then at the very end, I'll talk a little bit about our empirical results that we get with the gamettes that we have built. So first, and this is like work that is kind of somewhat old. But what we have done in the very beginning was we tried to build agent models or decision-making models based on this idea of, if I make a decision, and then if I imagine what everyone else is going to do, and if I propagate this for like kind of let's K periods in ahead, I can then take the optimal decision that I need to do right now. Right. So we can model this kind of a decision-making framework as a partially observable Markov game model. And then we can put this into our simulation as at least one agent's behavior and see what outcomes we get on different types of questions. So this the evolution of this game or of this partially observable Markov the decision-making game is that at each trace, you're at a state at each time step, and each agent has access to only a partial view, or could be a full view, but some view of the state, and that's an observation. And the agent, based on its observations, maintains a probability or a belief of being in some state, right? And then it has a set of actions that are possible for the stakeholder, and basically all stakeholders simultaneously chooses an action, and then based on their beliefs and based on kind of our kind of parameter setting in terms of saying like, okay, how much should you propagate, how much look ahead should you have, and what we try to do usually is like try to say that, okay, humans have this much propagation power, right? So we do something like that. And then based on once every agent simultaneously makes a decision, the world changes as a consequence of all agents' actions. And then each agent is rewarded based on what happened at that time step. So as I said, the planning horizon is basically how much into the future the agents are planning. So we're not looking at this as a model where the agents can look ahead for like infinitely or for a very kind of long time period, because we're really trying to model human behavior. So we're letting the agents plan ahead only for a limited number of periods. And of course, that also makes the computations manageable. Otherwise, we wouldn't be able to solve these problems. So I want to talk about a few things about our results. There are multiple papers around this, the results we have. I'm only choosing a few things that I want to mention here. So to start, I'm going to introduce the supply chain that we really work with. It's a very simple one where we have 2 manufacturers, 2 distributors, and 2 health centers. Okay, and that's it. And what we're going to observe is, or what we're going to do in the simulation is we're going to put in a disruption to one of the manufacturers. So the type of decisions that each echelon can make here are the following. So the manufacturers are making production decisions, okay, and they only have one customer, so each kind of directly go into the distributor. So whatever they have in their stocks, they will allocate it to the distributor up to the amount that the distributor ordered. And in this setting, what we're going to do is we're going to have the manufacturers just make decisions on a base stock policy. The agents that are somewhat interesting are the distributors, in the sense that they have to both make ordering decisions from the manufacturers, but they also have to make allocation decisions for their customers. And the allocation decision, of course, becomes interesting when they don't have enough stocks to satisfy all the orders that they have received, right? So here, what we do is we allow the distributors to make different types of use different types of allocation behaviors. So for example, one is proportional to whatever the demand is. The other one is preferential. And basically we use this theory of mind or partially observable Markov partially observable Markov game models to make these preferential decisions, okay? And then at the health centers, they're also kind of interesting. Their decision is to order from the distributors, but they also have to decide on not only the total order amount that they want to put in, but they have to decide on which distributor they're going to give their orders to. Okay, so again, there are two policies that we're allowing the health centers to use. One is just equally allocate your orders to the 2 distributors. The other one, order based on trust, which means that I'm going to look at my kind of fulfillment rate from each distributor over the last couple of periods and kind of proportionally order based on trust from that distributor. Okay. So, and then I'm going to say some things about how things change when you have different disruption profiles, but we'll talk about it when we get there. So the trustworthiness mechanism is extremely simple. We smooth it out in the sense that, we decide how sensitive the health center is to what has happened over the last period versus over the last, over the entire time horizon. We control that with this sensitivity parameter delta. So if delta is high, it means that we are putting in more. If delta is high, we're putting in more trust into what happened in the last period. Okay, and then the way that we're updating or the way that we calculate or evaluate what happened in the last period is we look at the actual amount of product that we received in the last period versus or over the amount that we were expecting to receive from the distributor. So it's just really a fulfillment rate type of an idea. So I'm going to go through a couple of experiments and just point out a couple of interesting things that we have seen. So when we look at disruption profiles that are short, and we have allocated one health center as the trust health center, which is they order, they split their orders to the distributors based on trust. And we allocate and we make the other health center just always equally ordering. They don't really care what's happening. They're always sending out their orders equally splitted to the distributors. And the other agents, everyone is just ordering on and making decisions based on base stock policies or proportional to demand. So there's like no other complicated decision maker in this first scenario. And what we see is that in this case, the health center that is ordering based on trust, the one that is kind of changing its behavior based on what's happening in the marketplace or in their order fulfillment, actually gets a benefit. So in these set of experiments, we've seen up to 15% less cost or more reward for the Trust HC health center compared to the equal health center. So that kind of made sense, right? Like, I mean, if you're kind of there and you're kind of changing your behavior, which is what the actual healthcare pharmacies, supply chain managers are doing, they seem to be benefiting. However, more interesting results happened later on. So let's just look at a scenario 2, which is very similar to scenario 1. But now the distributor that is the customer of the manufacturer that got disrupted, now we gave them a theory of mind reasoning, which is this kind of looking at it as modeling its decision making based on this partially observable Markov game with a time planning horizon of six time steps. And in that case, what we have seen is that, which was really surprising in the beginning, was that this distributor, who was kind of the smart distributor, actually started to prefer the health center that was ordering equally or splitting its order equally. And in fact, the health center that was changing its behavior based on trust ended up incurring 80% more costs compared to the health center that was equally ordering. And this was really surprising to us in the beginning. But then, of course, as we looked into what was going on, things became more obvious but interesting. So in the bottom, I have 2 graphs. On the right-hand side is the trustworthiness of the trustworthiness metric that the health center is calculating for the two distributors. The red one is for the distributor that's not getting disrupted, and the blue is for the distributor that's getting disrupted. So what you can see here is that as a disruption happens over at time step 70, the trustworthiness of the distributor who's impacted gets down. Okay. And as its trustworthiness gets down, and now if you look at the graph on the left-hand side, what happens is the orders that the health center, the trust health center is sending to distributor goes down, and then the orders to the other distributor goes up. Of course, what happens is the distributor that is not getting disrupted is not expecting this very high increase in its orders, right? And then it's not able to fulfill these orders, and hence its trustworthiness, which is this red line here, also starts to go down. And then we get into this whole bullwhip territory, right? Because the health center that is ordering based on trust then starts kind of oscillating because no one is making them happy, right? At the end of the day. And what happens is when you have this more smarter decision maker at the distributor level, they at one point realize that there's no way to make this trust health center happy, and they start not allocating products to them because they just go with the equal health center because they think it's a losing battle. So at the end, the trust health center actually ends up hurting itself by this kind of very oscillating behavior, which is, if you go and read and talk to people in this marketplace, you see that that's actually is a big problem, and everyone talks about this kind of behavior and how it's really hurting the entire system. So this is kind of summarizing what I've just talked about. But then the question was, does this mean using trustworthiness always hurts the system, right? Is that really true? And then the answer is no. And it's all about the sensitivity that you use in the trustworthiness kind of measure in terms of when do you actually start, how much weight do you give to the last period versus to the rest of the history, right? How sensitive are you to what's happening today versus kind of looking at history? And what we have seen is that for the scenario and the disruption we saw in the previous scenario too, actually, when we start changing the sensitivity factor, what we've seen is that if the Trust Health Center used a sensitivity factor that was much less or smaller, they would have been better off. So the blue is the red is the cost of the Trust Health Center, and what you see is that for smaller delta values, actually they were doing much better in terms of cost. Then we were like, okay, so what does that mean? Does it mean that, like, why is this happening and what does it mean, you know? And, or is that kind of common for all disruption scenarios or profiles? And the answer was no, right? So actually, it turns out there is a right sensitivity level for a disruption. So for example, if you have a very long disruption, it pays off to be as highly sensitive as possible. You are better off if you're more sensitive under a long disruption. And then there's a lot of stuff and analysis that we've done in terms of trying to understand this, but I think this graph just kind of explains what's happening. So look at the two different disruption profiles. On the left, we have a small, short disruption. On the right, we have a long disruption. And the blue line is the order, the order that the health center, the not disrupted distributor is receiving. So what happens is that for the short disruption, the not disrupted distributor starts receiving a lot of orders, but the orders come in after the disruption is over. So it's almost too late, right? However, for a long disruption, the increased orders at the not disrupted distributor actually gives a good signal into a problem in the system, and it causes it to start ordering more from its manufacturer, and the manufacturer starts processing more. But because the disruption is long, the lead times actually work in such a way that the effect of this increased production on the not disrupted manufacturer comes into place while the disruption is still going on, and it helps everyone, right? So then, I mean, again, like when it's explained, it's not so surprising, right? But it took us a while to explain all of this behavior. And then actually it's really interesting, like there's like these things are not linear, like sometimes with moderate disruptions, you actually do worse. And that really kind of points to a few conclusions. So the most important thing is that it looks like the way that the health centers should behave, or the sensitivity, should be really adjusted based on the disruption profile. However, there is no visibility in the supply chain system. So that's really hurting everyone, because if no one knows what this disruption is for and how long it's going to take and what is its magnitude, then no one can really adjust their behaviors or their sensitivity to this, to what's going on in reality, right? And that's kind of one of the big kind of points that we're trying to make with this stream of work, kind of saying like, you know, you have to match behavior to what's going on, but if you don't know what's going on, you cannot match the behavior to actually optimize not only the stakeholder rewards, but also the entire system rewards. Okay, so this is one stream of work. I'm going to go, given the timeline, I'm going to go very fast on this deep reinforcement learning-based decision makers, partially because at the end, the type of results that we get are very similar to what I've already told you. So it was kind of interesting to put in this different type of a decision-making model that doesn't depend on complex modeling of the uncertainty, complex decision-making, right? We were just like building a learning model. What we've ended up seeing is that the results that we got was very similar to the previous set of that we got from the previous stream of work. And let me just see what I want to tell you here. Yeah, we have a similar system. We used an advantage actor critic gated recurrent units, deep reinforcement learning algorithm. We've adjusted exploration and learning rates dynamically, you know, like we've done all this cool stuff. And then our state space is kind of what you would expect, like it's included inventory, demand, backlog information. What is maybe most important or interesting is at the bottom in this blue box, which is our state space included a vector of history of the state spaces. Given that supply chains have a lot of lead times, it is not enough just to look at what has happened or what is happening in this time period. It's really important to look at what was happening in, let's say, the last M periods, because I need to understand if my order that I placed in the last M periods is arriving now, how much delayed it is, right? So you really need to properly model these supply chain dynamics. You really need to keep a history of what was happening in the last certain number of periods, and we call it M in this presentation. So we build a reward function based on 5 different elements. Some of it is on order fulfillment, some of it is on inventory levels, backlogs, and so on. I'm sorry, I'm going to go through this fast because it's just, if I go into details, it's going to take a lot of time. So we have seen a couple of interesting things. First of all, the length of the history in the state space really impacts outcomes. And what we have observed is that the length or the history that you should be looking at should be really correlated with the lead times that you're observing in the system, okay? Because if you look at a shorter history, then you're not really capturing a shorter history than lead time, you're not really capturing the dynamics of the supply chain. If you're looking, on the other hand, if you're looking at a history that is longer than the observed lead times that you're getting, then you're maybe complicating things too much. You're just keeping too many things, and it's just kind of diluting the decision, like what's happening right now in the supply chain. You don't really want to know like what happened 6 months ago, right? And what is effective was that to kind of keep track of the observed lead times, okay, and make decisions based off the observed lead times. So as your supply chain situation is changing, for example, you have a stable supply chain versus a shortage supply chain, your observed lead times change, and you should be adjusting your decision-making based on these observed lead times, okay? I'm not going to show you so like those 2 slides were kind of the proofs or like kind of why I've made those insights, but we don't have time for that. The second set of insights that I want to mention is that it's very similar to what we have seen in the previous stream, which is the learning decision makers reacts differently under different trust sensitivity factors. Again, like if the health centers have different trust sensitivities, they're actually inducing different types of behaviors on the learning agents. And it seems like it's good to have some sensitivity because it acts as a signal to the learning agent to kind of change behavior and adjust behavior. But if you have too much sensitivity, particularly on on situations where there is no disruption or there is like little disruption, then it's actually kind of affecting the system and the outcomes of the particular stakeholders in a bad way. So again, our biggest conclusion was in the bottom, which is, like we really need to adjust trust sensitivity to the disruption profile. And that is like when that adjustment is made, then even the learning agents make better decisions because they're getting a much better feedback from their customers. So these are, so I have like maybe 5 minutes and I want to say a little bit on the schemats and empirical work, if that's okay, Lauren. Yeah, okay. So, so then, we can take out one of these distributors or models, and we can put a human into it. And we do this through these games. We have a whole gaming structure. It's the same supply chain I've shown you before. We put Kate in, or someone who is impersonated by Kate as the supply chain manager at this distributor. And we run 2 versions of the game in these experiments that I'm going to show you. One is without information, which is the information we're talking about here is the manufacturing inventories. So like kind of you get an idea of like, what is the situation in my manufacturer? And so as I said, we run 2 versions of the game, one with that information and one without that information. So we do look at 3 things, or we do analysis in 3 levels. First, we want to understand the system, like what is this state of the system. Is it stable? Is it under, under duress, or is it like recovering? And we use principal component analysis and hierarchical clustering to do that analysis. Then we look at the behavior of the agents. And to do that, we use hidden Markov models to understand the behaviors. And then we look at the interaction between the system and the behavior of the agents. And we do that through frequent sequence analysis. Okay. So a couple of interesting things. On the system level, we were able to identify 5 distinct phases if you look at the timeline. And what we see is that you have stable phases in the beginning and at the end. We have a phase which is where the manufacturer gets disrupted, and then that leads into a supply disrupted state, and then finally you get into recovery, which then takes you into stable system again. And the interesting part was we were really very distinctively and statistically significantly able to identify 3 different types of behaviors in all the people who played our game. We had hoarders who really deviated from kind of suggested order amounts that were coming out of base stock. They were over ordering most of the time. We had reactors, which were the people who kind of followed kind of the base stock suggested order until there was a disruption. But after the disruption, they started to hoard and they kind of like started to behave very erratically. And then we had the followers who basically never changed or deviated from what was suggested. Okay, so 3 different groups of people. And I promise this is kind of like really the last interesting slide. And what we did here was we looked at the 5 different phases of the system. On the top, stable, into disruption, supply disruption, recovery, and stable. And then for each of these phases, we looked at the 3 different characteristics of behavior. So the top row is the hoarders, middle is the reactors, and the bottom is the followers. And then at each phase, you have the 2 conditions in the game with no information and information. Okay, so here are the top 3 things, takeaways. In general, sharing and blue was over ordering, okay, and the darker the blue it got, the more the intensity of the over ordering was indicated. Okay, so first of all, when we had information sharing, we see that in general the over ordering was decreased. However, when people were kind of faced with disruptions, actually they ordered more. I mean, the hoarding behavior increased. The most important thing was the following. If you look at the hoarders here, when we look at disruption phases and when we look at the situation where there is more information, the hoarders actually ordered more when there is information in a situation where the disruption was going on in the system. So what this really tells us is really kind of almost 100% matching what we hear from the industry or see in the industry, right? Information sharing is great, but at the end of the day, if you're really dealing with a behavior type that is hoarding, and if you give them more information, it might actually lead to more hoarding. So that's actually is kind of an interesting finding, but also like we work with some people who are really, really advocating for kind of differentiated information sharing, which could be problematic, of course, but seems to be maybe necessary in a situation like this. And yeah, and I think that's it. I'll just finish here. Only a few minutes over time. So, and I'll take a few questions if there are any, or if we have time.
Great. Well, thank you so much. We'll clap, or I guess virtual clap, for our speaker. Thank you, Ozlem.
Sure.
Are there any questions from the audience? And I guess while we're waiting, if people are thinking of their questions. So this game simulator is very interesting to me. So I'm wondering, like, when these people were playing this game, did they play it once and then like every run is independent, or was there any kind of if you shared the results with people, would they learn over time kind of, oh, this is how disruptions are handled? I'm wondering if there was any kind of.
I mean, that's a good question. It was just once, and they're just independent. But we did have, I mean, not kind of related to your question, but a little bit more information on our players is that we did have a very diverse group of people. Like some of them were our students in our classes. Some of them were kind of my students in the executive class that I do with Georgia Tech, right? So like a lot of kind of practitioners. And then some of us like just the Amazon Turk. So like just really random players. And the interesting thing was, it's kind of like this, the beer game results, right? Like no matter which group you look at, you kind of got the same result.
Yeah, that's interesting. All right.
I had a question too. I don't see any in the chat. So wait, actually, there's a hand raised by Michael Carter. So
Sure, go ahead.
Here, Michael, I will try to. Okay, I think you're able to unmute.
Oh, there we go. I can, yes. Thank you, Ozlem. That was lovely. I do a lot of work with supply chain in healthcare, mostly with OR supply chain, and I mean I see the same kinds of issues. The lack of information, the lack of visibility is just really screwing up the way people place orders. Have you looked at that at all, or?
I mean, in general, like what you're saying is obviously very true. And so like we haven't really looked at anything else other than just kind of, as you said, like knowing that this is an issue in general supply chains. What we believe is happening here is that because of the context, you actually get kind of exponentially worse hoarding behavior. It's and really, so I mean, Michael, I don't know all the supply chains, but what I know from this one is that also the information, not only that it's like almost there is no information being shared, but also the information that's being shared is terribly wrong. So we look at, so I didn't talk about this in this presentation, but there's another stream of work we do where we analyze what the distributor is telling to the hospital in terms of the expected replenishment time, right? And we have historical data on that, and it is so wrong. It is terrible in the sense that it can be like they can tell the hospital like you'll receive in 2 weeks, and then they'll get it next day. You'll receive it 2 weeks, they'll get it 10 weeks from now on, and then every day that information keeps getting changed back, like up and down, and it seems like there's really no correlation with the truth. And so the hospital systems are really trying to make these decisions where like there's like seemingly some information is coming in, but there is really like nothing is believable, or is not even like you can't even, it's really interesting. Like we've been doing all these analyticals, like analysis on this data, expected order receive dates, and there's really no correlation. Like we can't get anything out of it that makes sense. It almost seems like these distributors are just making up things.
Yeah, I mean, I'm seeing a lot of the same issues in OR supply chain that lead times are crazy. That when hospitals place orders with distributors, they either get it tomorrow or maybe a month or two.
Yeah,
and
exactly.
Usually it's tomorrow, which really throws people off. And then every now and then, there's a problem with the production that nobody knows about, and so they start ordering a pile, and oh man, it's awful.
Yeah,
it's healthcare. It's a mess.
So maybe we can wrap up with Guillen's question, and then we'll let people move on to their next calls if they need.
Yeah, sure. So one of the things that struck me was like your analysis on how different types of disruptions might cause different types of behaviors and decision makers. In practice, something I was wondering was like in practice, like how much awareness do people have about the type of disruption they're experiencing? And I can imagine in real time, like you might like with COVID, you didn't know how long that was going to last, right? And so I'm wondering like if there are maybe if you had already kind of considered this setting, or if there are extensions of the work that kind of look at like the partial observability or the need to estimate like the type of disruption that's occurring.
Yeah, definitely, Jen. I think that's like one of the big streams of work that's kind of going on right now. I mean, in reality, as I was telling Michael, most of the stakeholders have no idea how long or how bad the disruption is. But we are like looking into some analytical models that are trying to kind of explain at least the impact of, you know, at least knowing something, right? At least the length of it. Is it like the length of it, the intensity of it, you know, and kind of trying to show some analytical results on the improvement you can make by having at least this information available. So yeah, I agree. It's really important. I mean, on one side, like I like the analytical models looking into this, but also on the other side, like it's just kind of in the industry, there is really like it just doesn't exist, that information.
Yeah. No, thank you. No, I think it's a really, really interesting idea and like very, very insightful. I thought, I mean, even in the setting where you do know what it is, there's a lot of insights to learn. So
Yeah, exactly. Okay, thank you.
Great. Well, thank you again, Ozlem, for your time and your wonderful presentation. And my apologies again about the technical difficulties at the beginning.
I know, right?
I'm glad people were able to stick around for some questions. All right, so with that, that'll be our first Informs Healthcare Seminar of the year. We'll have a couple more coming up soon, so check your Informs Connect for more announcements on that front. And then thank you again, Ozlem.
Thank you, Lauren and Jan. Thank you. Bye.
thank you. Bye.